Okay, thank you. So we're looking at non-degenerative cervical myelopathy and a bit about the pathology itself, and then we're going to look at three cases that we've done this year. So myelopathy, if you Google it or you look in a dictionary, a collection of symptoms and signs that result from severe spinal cord compression, or in other dictionaries, dysfunction of the spinal cord. And we know these to usually be associated with upper motor neuron signs. And on the right of the picture, you can see the modified Japanese Orthopedic Association scoring system. And again, it just points out what we'd expect to see in a patient. So upper extremity weakness, lower extremity weakness or imbalance with walking. Thanks, and then sensory symptoms in the upper limbs, and then at the bottom, bladder and bowel dysfunction, which is usually a late finding. So this is 2020. So first, just signs to look for in clinic, to hone in your diagnosis and to work out whereabouts you need to get your MRI scans, especially as NHIF doesn't usually cover a whole MRI spine, so you need to target the area. Finger escape sign, so that's putting your hand, asking them to adduct the fingers and just watching the little finger fall out. Intrinsic muscle wasting, not something we see a lot of in the UK, but is certainly more prominent here as people present later. The most common thing often is instability of gait, clumsiness of feet, patients saying that it feels like they're walking on sponges or uneven ground. And then in your clinical exam, you can often find increased tone, Hoffman positive test, inverted supinator, Babinski, clonus, hyperreflexia. So this is 2023's caseload. So we operated on 20 plus degen myelopathies, 6 intradural tumours of the cervical spine, and I've grouped them into like obvious compression versus instability that may or may not have compression as an aspect of that. So we've got infection, which in this case was TB, trauma, this is delayed presentation trauma, so C-spine injuries that are unstable, causing neurology, but presenting to us several months after the original injury, and then congenital, mainly relating to C1-2 instability. So 3 cases to look at to try and learn from this. So case 1, 50-year-old lady, left side weaker than the right, 3s out of 5, and the MRC grading. She's wheelchair bound, she's lost bladder and bowel function, and notably, she has very shallow breathing and unable to hold breath. So the holding breath thing is going to be a common theme throughout all 3 of these cases, as is their cough. And I think that's partly because of the setup of our hospital. It hasn't moved to the stage of having pre-op anesthesia assessments. The surgeon is the anesthetic assessor, and then we go to theatre. So this is her scan. So I'm going to ask you you're allowed to do 2 tests. You're allowed to pick your tests. Someone shout out what you do. You're allowed 2 tests before we go to OR. You can't be wrong, I've just chosen my top 2.
Get axials.
Okay, there are axials, you'll see them later. So this is a film scan, so often the patients won't have got a CD imaging, so you'll just be looking at it into the sunlight, trying to work it out, but we have got axials.
CT scan?
Yeah, CT. Okay, that's one of mine.
Yeah.
And why are you doing the CT?
To see whether it's bony or just, it looks like it's bony.
Great. Okay, I alluded to it, lung function tests, but in our setting, that might just be holding breath. So there's 2 studies that looked at breath holding or single breath counting as an accurate proxy of forced vital capacity in ALS patients and in degenerative cervical myelopathy patients. So the CT, this confirms what you said you might find. So highly calcified, very little space for the cord. Surprising she is even as well as she is. But it does explain why perhaps the breathing is also being affected. You've got some slight thinning of the lamina to make space, as this is a chronic thing that's been happening over many years. And this is a post-op scans. So I didn't go for complete excision. We are in a resource-limited setting. There's no CUSA. We can use a scalpel or we can use monopolar. And the attempt to use rongeurs was ineffectual. You could use an upcut, but it just was really, really tough tumour. The histology was a pseudomonas meningioma grade 1, so we can be encouraged that this is unlikely to grow back too quickly. She had an immediate improvement in upper lower limb function, and at 12 months, she's just sent us a video update, but she's walking, but with the assistance of either a friend or holding onto a bar or something like that. She's home without oxygen requirement, her continence recovered, and we'll look at, I've sort of presented them with the happy story and then what really happened. So, perioperative complications. Can anyone see what this chest X-ray shows?
Hemothorax.
Okay, we've got a hemothorax as a suggestion. There's no fluid line, but you are right, the right lung is odd.
Just elevated hemidiaphragm.
Yeah, great. So we've got an elevated hemidiaphragm on the right, considerably different from the left, but we've also got a lung fissure marking that would suggest perhaps a lobar collapse. So this lady stayed with us for almost 6 months, on and off ICU with recurrent chest infections and oxygen requirement, and in the end required, in fact, okay, I'm not going to tell you what she required yet, but why? What's the pathology behind this, based on this scan and this picture? Yeah, go for it.
I think that would be. I think that would be an affection of the C4, the C3/C4 nerve, the ansa cervicalis. I think on that side. It's on the right side, yeah.
You say infection or just
affection, like
yeah,
through the tumor, through the surgery, manipulation.
I think he's politely saying I trash it.
Yeah.
So that's correct. So when I sort of planned the case, and if you look at literature, it's okay to have a hemidiaphragm in a normal physiologically well patient. They can function normally. So I did have the decision surgically to decide, am I going to cut this? Am I going to try and get more of a resection, create more space? And I was like, yeah, I'm taking it. And so, unfortunately, she didn't quite tolerate it how we'd expected. And that comes back to the pre-op anesthetic assessment done by the surgeon, which was she couldn't really hold her breath. Her diaphragm was already struggling. All of her accessory respiratory muscles were also failing. She had wasting from the neck down. And yeah, she didn't have a normal respiratory function when we started. So this is after a minimally invasive, as I said, we benefit from cardiothoracics on site, and they did a VATS procedure just to pin the diaphragm down on the right, which allowed or prevented recurrent lung collapses. And that was all she really needed, that and time. So the neurological recovery from decompressing the C-spine eventually allowed her to rehabilitate the chest adequately to be off oxygen. But quite a journey, and if asked to do that again, I'd say no. Or at least I'd counsel the patient with much more appropriately. So this is just a bit of the anatomy behind it, so you can see this second picture just shows, for those of just basic anatomy, that C8 nerve, all of the nerve roots come out above their respective vertebral body. So we've got on our CT the C3, 4, 5, which make up the phrenic nerve or ansa cervicalis. And they power the diaphragm. That essentially provides the largest part of our respiratory ventilation muscle, about 80%. So C3, 4, keep the diaphragm alive. Most people would be okay with this injury, but not someone that's predisposed to neuromuscular respiratory dysfunction. And when I looked into the literature, it's not just traumatic C-spine injuries that suffer from this. So if you have a C5 C-spine injury complete, you lose 50% of your FVC. And if you're a degenerative spine patient, chronically compressive, then again, you have, in all 5 papers, it showed reduced FVC values for these patients. And it's obviously to what degree as to how it impacts our surgery. So take-home message, assess your FVC pre-op, so breath holding, counting, or if you do have the luxury of lung function testing. All our patients that have this risk should be planned for CPAP post-op, so when we extubate, we just support their breathing to reduce the risk of atelectasis and chest infection. We also, literature shows in C-spine trauma that abdominal splinting facilitates our ventilation effort when we have accessory muscle weakness by increasing intra-abdominal pressure. So the diaphragm can then pull down, but as it relaxes, it pushes up, so it increases expiration. And so we did try that on her. And then just note for the future, if you're going to take C3, 4, 5, just check their function beforehand, as it may not work out as well as it did for this lady eventually. Case 2. So just because of the talks we had yesterday, it's worth mentioning none of our patients had funding, but because they were of a chronic nature, we were able to assess them, send them, advise them to pay for the NHIF, which takes about 8 weeks to activate, and then use that to fund their surgery. So this is a chap for that didn't work. He doesn't have a Kenyan nationality and couldn't use NHIF. He'd noticed 8-year history of neck swelling, both in the anterior and posterior neck triangle, neck pain and difficulty turning his neck. He had clonus and spastic gait, but wonderfully he had excellent breath holding with no limitation. And at a peripheral facility, he'd had a biopsy of the superficial neck mass. So this is a post-contrast CT head showing a very large mass extending anteriorly and posteriorly of the C1 and C2 vertebral body. And you can see on the far left image that the tumor is coming from intradural location, and you can see the peg just above. This is just a soft tissue view, and it highlights the vasculature. So we've got the tumor now shows it's exiting the foramen. You can see the vertebral arteries in foramen transversarum and the destroyed transversarum, and then you can see the internal carotid displaced anteriorly. If you look at the literature, it is possible to tease off the internal carotid from this type of tumor. We think I know now, but at the time we felt it was growing from within the cervical canal outwards as a C2 schwannoma. And so the thought was, can we cure this guy? If it's a grade 1 tumor, can we achieve complete resection? So both me and Fraser have come to Kenya as our first consultant job, and been overwhelmed by the pathology and rely on the expertise of colleagues, friends, both in Kenya and at home. And so I sent it out to our WhatsApp complex spine MDT, and sometimes the suggestions you get are rather bold, and you just have to navigate through that. But this was one of the papers I was sent, that at Queen Square they've done 45 of these where they coil or balloon occlude the vertebral artery, and in those 40 plus patients they've had only one stroke, a cerebellar stroke that resolved within 2 weeks clinically, and they advised ballooning it and then taking it. Now obviously we couldn't balloon it, but I did plan the surgery so that I could take it. So that involved getting proximal and distal control, so opening the dura at the craniocervical junction, looking at the vertebral and making sure I take it before pica, I didn't take it at this point, I just had access to it, and again drilling out half of the C3-4 facet so I could expose the vertebral artery. Again, the plan was to place the clips and then get complete resection. But it was a two-part operation, the posterior part and the anterior part. And during the process of removing the posterior tumour, decompressing the cord, it became apparent that the tumour was, in the other surgeon's opinion, made of cement. To me, it was, very, very tough. So we had to use monopolar to resect it. I used Doppler to identify the vertebral artery, and just got closer and closer to it, but held off doing occlusion and sacrifice, as I wasn't sure whether they would achieve complete resection of the tumour elsewhere. And as Dr. Henderson or Fraser has mentioned earlier, functional outcome is key. If your livelihood is based on your function and you change that, the outcome becomes maybe a social outcome, but it's very severe. They were unable to remove the anterior neck tumour because it encapsulated the facial nerve, and felt that wasn't a sacrifice that would be warranted in him on balance. So despite damaging the facet joint, we just accepted that we weren't to take the VA. I laid fascia lata graft outside of the dura. I kind of had to do a T resection as the nerve root came out, because the tumour was the nerve root essentially. So it was a large exit. Repaired that with fascia lata, and felt that would, even as the tumour grows elsewhere, it will certainly give us several years. He returned to Burundi, retains his function, and this is him showing off down the line. And his main complaint will be he's got really restricted neck movement, but it's predominantly due to the tumour underneath sternocleidomastoid. And you can see the mass as he turns his head and my incision. Okay, case 3, 30-year-old female. The common theme of history, upper limb, lower limb dysfunction, weakness, and often with myelopathy, their ability to walk is taken before their power. So they can't walk, but it's often a large part due to loss of proprioception. She also had cervical medullary syndrome, so nystagmus, voice changes, swallowing difficulties. She remained bladder and bowel intact. And again, having been burned by a first patient, everyone gets breath testing before we're even thinking about surgery. So she was marginal, 15 seconds. I would say that's my cutoff. 14, we're not doing it. So I was ready for the consent involved trachea, long ICU stay. Again, no funding, but was able to get the NHIF approval to go ahead. This is her MRI spine on the right, and a CT showing the syrinx. So again, consulted friends abroad and in Kenya about how to take this on. There's a lot of discussion about this, but it seems that the understanding has moved that this is a disease of C1-2 instability. And when you look at the CT, there are a few abnormalities. One, you almost lose the lateral masses as it goes down, so there wasn't much to fix to. The pedicles were tiny, but possible. But I think at C1 it was not possible, that you couldn't even, do I see it there? Yeah, C1 is already fused to the back of the epistemion. She also had this large bony septum that meant doing a suboccipital decompression involved quite a more involved process. Retractors in, going much deeper than we would have hoped. And yeah, I opted to do as secure a fixation as I could, so I did an OC fixation, skipping C1, C2, C3, C4. And I guess if it's not obvious, it's all about navigation. And these are the screws. This is a 6 or 7 month post-op MRI with resolution of the syrinx. There was immediate improvement in her upper limb function. And I didn't go as aggressive as was potentially suggested by others to do a duroplasty, open the dura, open up the arachnoid. As I felt I could go back if it wasn't enough. I mean, if the operation's going to take all day and you're entering into the evening, again, it's not a... everything sort of feels like it's for the first time. So training the radiographer to take pictures at the right angle, it's new to the team. So we just tried to do the least we could that would help. So improvement of swallow, but required a PEG for 4 weeks. Improved cough, recovery of proprioceptive loss, and now back working in a shop. But what actually happened? Okay, so they come out a bit too quick, but this is her OC fix, rather long rod, but she did well. She had great neurology post-op. We extubated her. Unfortunately, it's the common thing you learn about in med school, but we went and blundered on and had the same complications. So, unable to breathe. We'd actually extubated her the day after surgery just to try and reduce airway edema from a long prone case. But on extubation, she couldn't breathe. She really was trying, but couldn't breathe. Attempts to re-intubate were near impossible just because of the change in neck position and its fixation. It was not possible to extend her, an already very short-necked lady, due to this deformity. So a crash intubation was done on ICU, and I think these are the events that scar you but also change your practice forever. So I'm holding the iPhone over them to give them light on a bed that won't go up, and we're doing an emergency trachea on a lady that I feel is about to die. And it's very stressful, and as a result our practices are changing dramatically. We have a protocol for extubation. Another thing to just flag up is the trachea strapping caused wound breakdown, which did heal by secondary intention, but again was an added stress. So, learning points, don't just place the screws for best fixation, you have to place them so you can put the rod in. I mean, I think I had great screws, but it took me about 2 hours to bend the rod to fit them. Keep asleep overnight, sit them up to reduce oral and tongue swelling, add some steroids in. We had done all of this, we weren't ready to go back in when we extubated. This is the step we missed, decuffing the ET tube and just listening for a leak. That was the missing part in the protocol that resulted in the crash trachea. And just be ready, maybe I think now we'd even inform our general surgery colleagues, maybe that's overkill, but just so they're on standby, because even getting hold of the equipment for an emergency surgical airway was a rush. And then after we'd seen the wound breaking down, we just opted to suture in the trachea, especially as it was a long-term trachea, so don't let the strapping go over your wound. So this is a simplified thing. So can they obey? Can they tolerate being off the ventilator with a PEEP of 5? Have they got a gag? Have they got a cough? And then do a cuff down leak. And I think if they don't, you may be up to 5 days waiting for this and it may just be that they don't get their gag back or they don't have a cough for several days afterwards. So those 3 cases, I hope, are going to just form in your memories the traumas of our experiences. Always get a CT or a CT angio prior to C-spine surgery. It's certainly needed for the planning, but you also may find some other nuances that could have been missed. Pre-op respiratory function, planned and controlled extubation, and this includes CPAP for several days afterwards to prevent atelectasis. And I guess if you take this away from the clinical surgical scenario, just in clinic, we've just got to educate and get these patients referred earlier, and that might be education of the patient population as well, because the outcomes from myelopathy are much improved the quicker we can get in. So yeah, I just wanted to say none of this is possible without our residents, without my partner, Dr. Henderson, and this is a group of people that have been giving us advice over the last 18 months. This is our team, and we also have to say thanks to Zinvi, who provide us with free implants, and Stryker, who've been providing us with drills and drill bits, the NHF doesn't cover instrumentation costs. So, it's not possible to do any of these surgeries for, I'd say, 95% of our patients without this support. Thank you.
We have time for one question. Anybody? Any questions?
I just have a short question. There's this discussion that we keep on having in Germany. If you have a myelopathy and you see this sign on the MRI, in Germany we are radical. If you see the sign, whether you see a disc prolapse or you see a pathology, the indication for surgery, the threshold is really low. So we decide to do surgery. How is it in Tenwek, and how is it in the US? What's the main? How do you go about it? When you see this, even if the patient is mildly asymptomatic, do you still opt to do the surgery, or do you just wait or leave it? Yeah.
I think in the UK we'd counsel the patient. Our adage is, if it's a difficult decision, let the patient make it. Now, I know that sounds a bit of a cop-out, but it at least means you won't have so much comeback around it, so you can give them the options. So we monitor or watch carefully for any deterioration, use the MJOA to watch for that. But you'd also say, hey, if you want to have a prophylactic or a early surgery, but they would have to have clinical signs. It can't be imaging alone, as we know that a large proportion of the population do have very snug cervical cords. But if you had signal change, then it's reasonable to go ahead. But if the patient doesn't want it, then we just give them the option. In Tenwek, I think there's so many stages to get through to get to a hospital. So that would be talking to your village and their reasons of why it's happening, and then you have to get to someone that even says seek healthcare, seek medical care, and then from there'll be a financial restriction, because to go somewhere, there's different cost gradients. Often for your outpatient, it wouldn't be covered by NHIF. So they'll often describe many years of seeking healthcare to eventually get somewhere where they get imaging and get a diagnosis for input.
Thank you. Great talk. Thank you so much.